Hello, my name is Jean-Pierre Després. I am the Scientific Director of the International Chair on Cardiometabolic Risk. And today we have the pleasure of welcoming Dr. Stephen Nicholls from the Cleveland Clinic. Steve has extensive research training in lipoprotein metabolism, as well as internationally renowned expertise in cardiovascular imaging. So thank you for joining us today, Steve.
Thanks for having me.
As mentioned, you have extensive training in lipoprotein physiology and cardiovascular imaging. With this combined expertise, what have you learned about factors involved in atherogenesis?
So, you know, the real advantage now with the technology that we have of imaging is that we can now image the artery wall in a patient at multiple time points. And so we can watch the natural history of the disease. And the sobering thought is the natural history of the disease is it progresses. But it's also given us a unique opportunity to be able to explore what are the factors that really drive that progression, and then secondarily, can we intervene? And what we've learned really is the importance of lipids. LDL is clearly a major factor in driving the disease. We've seen now in a number of studies, we've used intravascular ultrasound to look at plaque. We've seen other modalities that have looked at earlier stages of the disease, and they've all shown the same thing, which is the lower you can get your LDL cholesterol, the better you do. Yeah. So that's an important take-home message. I think what we've started to embrace more from a lipid perspective in the last decade, however, is the importance of the other lipid factors. The protective lipid factors, HDL, ApoA1. We've seen now in a number of different analyses, whether we inject HDL or whether we look at relatively small HDL increases with statins, that those factors are important in terms of promoting regression of disease. And so now we're getting this balance. So if we can get the atherogenic lipids down and the protective lipids up, that seems to equate to the best scenario to promote regression of disease.
I often see in my own lectures that we have made over the last 50 years remarkable progress in our understanding, I would say, of the key drivers of cardiovascular risk, such as smoking, cholesterol, hypertension. As you know, there's this evolving now landscape of modifiable risk factors because of the sedentary, affluent lifestyle of the population. We see now a lot of obesity, type 2 diabetes. What are the implications in terms of atherogenesis? Could you speculate on that?
Well, I think that those are individuals in whom atherogenesis is a major problem. We see much more accelerated progression of disease in patients with diabetes. We're seeing a much greater importance of hypertriglyceridemia, low HDL as a phenotype, even in patients in whom LDL cholesterol really doesn't look so bad. And in fact, we've seen that in diabetic patients, the triglyceride HDL cholesterol ratio being a very strong predictor of disease progression and an important target. So as we see abdominal obesity and type 2 diabetes rise, you know, we're seeing a lot more of these kind of lipid phenotypes, and we think that they are particularly atherogenic. And then above and beyond that is then looking at the LDL particles themselves, the fact that LDL cholesterol doesn't give us the whole story. It may appear to be normal, but underlying that may be a patient who has a lot of small, dense LDL particles. And again, we think they're more atherogenic. We see patients in imaging with more small, dense LDL progressing a lot more. And so as we've become more obese as a population, I think these are the lipid phenotypes that are becoming more prevalent, and as a result, it's becoming a major problem.
I think cardiovascular imaging has tremendous potential to better understand the contribution of these emerging markers. Now, in the landmark Saturn trial for which you were the principal investigator, you have reported plaque regression. You know, it's one thing to slow the progression of the disease, but to induce regression, it's really something spectacular, fantastic. What are the winning conditions to induce regression?
Well, Saturn really gave us a nice opportunity to really explore patients with coronary disease treated with the highest doses of the most potent statins. And that was an important question because we find that in clinical practice there seems to be some reluctance to really push the doses of those drugs. And the reluctance is not only not only the physician, but it's also the patient. You know, there's a real kind of fear that increasing the doses comes with some safety issues and at the same time questionable increases in efficacy. So what we saw in statin was that in both arms, you basically got an LDL cholesterol below 1.8 millimoles per litre. You in fact got an HDL cholesterol that was somewhere in the order of about 1.3 to 1.4 millimoles per litre. This was about the highest we'd seen in HDL in a large statin trial. And that combination translated to profound regression. We saw much more regression than we'd ever seen in any other study. Not only the magnitude of regression, but even the percentage of individual patients who regressed. 2/3 of patients who kind of achieve those types of lipid levels with high-dose statin therapy, you know, can achieve regression. And then the additional benefit and take-home message of the study was really the safety profile looked very good. And so it really underscored that, you know, you can take high-risk patients and really push the doses of a statin to really achieve the lipid levels that we need to achieve to promote regression. You can do it safely.
Yeah, and inducing regression in high-risk patients is certainly something that you want to achieve. And you pointed out that a fairly large proportion of those patients were able to achieve that objective. You also pointed out when you previously commented on your study that you still have 1/3 of patients showing no regression or progression. So that gives you also an opportunity to explore, right, those potential additional factors that could contribute to still the progression of the disease when facing a fairly low LDL cholesterol.
Yeah, so I mean, we're in the process of looking at that specifically in statin at the moment. We have looked at it in a slightly different way before, and that was that we've known for some time that 1.8 millimoles per litre seemed to be about the target at which you started to regress in terms of getting your LDL cholesterol low enough. And we had previously asked the question, well, how many patients who get down below that level actually progress? It turns out about 1 in 5 patients still progress, and the predictors of those patients progressing are not necessarily that surprising. They're diabetic, they're people whose blood pressure goes up, they're people whose HDL cholesterol goes down, and there are people whose ApoB goes up. And I think there's 2 take-home messages there. The first is that it really underscores that this is a multifactorial disease. So yes, you can achieve very good control of LDL, but if you have lots of other risk factors, you'll still progress. And you know, we know in the abdominally obese patient, they tend to have a lot of risk factors. So we really, you know, this really is very pertinent to that kind of patient. The ApoB story, I think, is also an interesting take-home message there, in that while your LDL cholesterol might appear to be okay, if you've got a lot of ApoB, it really reflects a patient who's probably still got a large number of smaller LDL particles circulating in the plasma. They can get into the artery wall, drive the disease process. And so, you know, we're continuing to learn more about that discord between LDL cholesterol and LDL. Again, it's probably important, particularly in the obese patient, the diabetic
and in the
patient.
patient with type 2 diabetes.
Absolutely.
That's right. That's very interesting. Now, obviously, that trial has, again, reinforced the notion that the primary target should be LDL cholesterol lowering, and a robust LDL cholesterol lowering would really be associated with benefits in terms of being able to induce regression. Now, you referred to that when you discuss, you know, again, what's possibly going on among patients still showing progression. And obviously it brings me to the next question, HDL cholesterol. The story has been rather simple for LDL cholesterol. The lower the better. But HDL cholesterol is a complex beast, right?
It is, and I think in its most simple form what we know is that consistently, while the population studies show us that there's an inverse relationship between HDL cholesterol and risk, it's not a direct relationship. It is curvilinear, and it's largely driven by the fact that if your HDL cholesterol is low, you have a high risk. They are the patients who we use more intensive management in terms of lipid lowering, blood pressure interventions, these types of things. What we don't know is is there a benefit in raising HDL? The agents we currently have in general are fairly modest with regards to their ability to raise HDL. That being said, there's now good data from fibrate and statin trials that show that those small increases in HDL do appear to contribute to some of the benefit of those drugs. The niacin story has perhaps become a little cloudier, and particularly in the setting of the wake of AIM High, so we await to see the results of the Merck niacin lipoprotein study to see if that will kind of shed more light. But at the moment, this is the real challenge, is that while a low HDL cholesterol is a risk factor, and HDL at least can have a biological role in protecting the disease, we are yet to see therapies that specifically target HDL, reducing cardiovascular morbidity and mortality. And so that, we're still kind of waiting to put all the pieces of the puzzle together.
Yeah, I guess as you pointed out, the literature is overwhelmingly clear that when you look at a group of individuals, the subgroup with low HDL cholesterol level, at any LDL cholesterol levels are at increased risk of coronary disease. The question is, what's behind that? What are the driving forces behind the risk associated with low HDL cholesterol level? Is there a causal relationship? Probably part of it is causal, but maybe also low HDL cholesterol is a marker that you're abdominally obese, insulin-resistant, hypertriglyceridemic with a pro-inflammatory profile, and so on. Which brings me to the issue of targeting CETP, which is a fantastic way to increase HDL cholesterol level. At this stage, obviously, we need further studies, but we know that with CETP modulation or CETP inhibition, we can get spectacular increase in HDL cholesterol. What do you think we need in terms of studies? Obviously, we need endpoint studies, but what are your views on this target?
Well, I think that it remains a viable question to ask. I think we learned a lot following torcetrapib. Once we learned that there were off-target toxicities, it gave ongoing hope that at least it was a question worth asking. And thankfully now we have 3 CETP inhibitor programs that are fairly advanced. One with a completely enrolled outcome study, one with an enrolling outcome study, and the third hopefully to start enrolling. So I think we're going to get the answers to some of these questions, but you kind of alluded to one of the interesting kind of side stories here, which is these agents, while they all target CETP, they do it to differing degrees. There's now the suggestion of potential differences between the drugs with regards to their effects, specifically on HDL particles and their ability to remodel, whether we modulate versus inhibit, and what the relevance of that we don't know. And a question we've asked ourselves for a long time is not only is inhibiting CETP a good thing, but is there a sweet spot? Is there too much? Is there too little? And again, until we see, thankfully we have got outcome studies, but then I think what we're going to have to do is when they're positive, then I think we need to go back and do some exploratory investigations to try and kind of appreciate really what's the most effective way to target CETP. Keeping in mind that CETP inhibition and a benefit may have nothing to do with HDL. They're great at raising HDL. Some of these drugs lower LDL 20 to 30% on top of a statin, and it's possible that they work just because they lower LDL. So it's interesting how those agents have evolved as HDL raisers, but whether their ultimate benefit has anything to do with HDL, we just don't know.
Well, since the studies, as you pointed out, we were certainly going to learn a lot about the clinical implication of modulating lipoprotein physiology beyond raising HDL with those agents. Now in closing, you have huge expertise in cardiovascular imaging. Obviously, our ultimate goal is to discriminate early those who are at high risk for or increased risk for clinical events. So how do you see the contribution of imaging, cardiovascular imaging in risk assessment at this stage?
Well, I think it's got a long way to go. I think that we now have the ability to see. Now, so we have eyes, now we need to train ourselves how to use them properly and then what to do on the basis of that. So We have been able to use it in trials to look at therapies, and that's important from one perspective. But what the average clinician wants to know is, as you said, can I use a given tool in my clinical practice to help me better risk stratify, help me triage a given patient to a more or less intensive therapeutic strategy, whether it just be lifestyle, whether there's a patient who requires more intensive medical intervention. That's the challenge. You talked a lot about modifiable risk, and this is perhaps where imaging can help us to some degree. I mean, we always have to keep in mind that as much as we talk about residual risk, that not all of that residual risk is modifiable. Mm-hmm. I mean, in clinical trials, that yes, some events continue to occur, but some of them occur in people who are elderly, people who have got advanced heart failure, poorly controlled kind of kidney disease, diabetes. You know, some of those things you probably can't have too much of an intervention in. So how do we pick the patient who's got the lipid-rich, inflamed, plaque burden disease as opposed to the more fibrotic disease? This is perhaps somewhere where imaging can be helpful in addition to other plasma biomarkers. And so what we really need moving forward is not necessarily new imaging, but clinical trials that ask the question, if I do the imaging, mm-hmm. does it change what I do as a physician? And does that ultimately change what happens to the patient? And I think if we had the ability to use imaging to essentially pick out the patients with the modifiable disease, one would hope that then you would change what you do and that would have a more favourable outcome for those patients. But we haven't done those trials, so we really need to do them.
They are certainly fantastic research tools for the time being, and again, very interesting questions that we'll be able to address in the future. Well, Steve, it was a pleasure doing this with you today, and thank you for your generous contribution. Thank you.
Thank you.